So you know where I am. Angela, would you like to start?
Hi, I'm Angela C. I'm with the University of Hawaii. I do community engaged research.
Terrific. Claudine?
So I'm Claudine Jurkovic. I'm part of the ACCEL CTR. I lead the Biostatistic Epidemiology Research Design Core. So I'm T2, T3, T4.
David? Chen?
Hi, I'm a clinician with iReach and ChristianaCare. My specialization is essentially violence, specifically firearm related. And I guess that puts me anywhere between T2 through 4, implementation of various programming and reiterating that.
Emma?
Hi, I'm a research navigator for Western Maine through Maine Medical Research Institute. And I'm also from the region that I'm a navigator for. And I suppose I would be more on the T3, T4, really on the community end of implementation.
What's a research navigator in your context?
Sure. So I sort of link, we have community-based participatory research projects that I work with. And then we also are working with clinicians who are doing projects based in the clinical setting.
Terrific. Kimberly?
Hi, well, thanks for having me. I'm a research investigator with Claudine at the Institute for Research on, I'm trying to remember our new acronym, Equity and Community Health. And my research involves access to treatment, integration, behavioral health in the primary care setting, and primarily focus on access to treatment for opioid use disorder, as well as other behavioral health concerns. So yeah, I would say my research is somewhere between, yeah, T2 to T4 on the continuum.
Okay, Martha?
Hi, I'm Martha Hall. I'm a professor at University of Delaware, and my home base is a little broad, so I'll make it really quick, but I'm in health sciences, biomechanics, computer engineering, electrical engineering, mechanical engineering, fashion, and entrepreneurship. So my research focuses on designing wearables that improve patient health outcomes. And I've never seen the T stuff before, so I'm guessing I'm between T2 and T3. Thank you.
Lee?
So I'm Lee Pachter. I am also at iReach at ChristianaCare. I'm a pediatrician, and my research has to do with the social and structural influences on health, specifically racism and child health. And I'm also recently getting into research in telehealth and virtual care. And I would say that my research is more on the T3 to T4 level.
Gwen?
Hi, I'm Gwen Angelette. I am a private consultant working on a number of community-based projects focused on youth violence prevention, community resilience, community well-being. In terms of where I lean towards T4.
Okay, terrific. Karen? I realize I'm using 4 minutes of our 15 minutes, so forgive me if I seem to push you along.
My name is Karen Huff. I support the Delaware CTR ACCEL program. I'm based at the University of Delaware, and I've worked with investigators that do basic science all the way up to T4, and we're hoping to have more investigators towards the end of the T3, T4 spectrum.
Okay, terrific. So could we have a volunteer for a presenter eventually to synthesize our findings? Can't be me. Gwen, can I volunteer you?
I think, wouldn't it be nice to have someone who has not spoken today?
It would be, maybe David. All right, David, would you be willing to synthesize it? Terrific, thank you. And Anuradha, I was asking, can you open it?
Yes, I have it open. Should I share my screen? Would that be the most efficient way to do it?
I thought in the interest of time, since Anuradha has done the Jamboard, we should just start. So what shall we identify? Yes, please share. What should we identify as your most pressing health need that we'd like to address together?
You can see that, right?
Mm-hmm. Yes. So it doesn't have to be perfect. It's an exercise. but it's best it comes from you and not from me. Is David the only clinician? What about, now my screen just moved, so I lost everyone. Kimberly, you're the navigator? No, I'm sorry, Emma, you're the navigator, right?
Yes, I am.
Can you identify a health need that we could address together?
Oh, sure. We have a community health needs assessment regionally, and the top need was access to mental health care.
Access to mental health care. Okay. So access, can you make it a little bit more general?
We can just say mental health care. That's
Mental
fine.
health care, okay. All right, so now we begin. We can begin anywhere on the spectrum. Honorata will open a Post-it note, and whoever would like to start should start with where your interest falls on the spectrum. Maybe since you named it, Emma, and you indicated access, maybe you could begin to place your priority on this, in this matrix.
Sure. So access to mental health care in the primary care setting is a concern. So that would be probably the T2.
Access,
Oh,
I would think
maybe
of,
T3.
I would think in T3, T4, right? Let's call it T3. Although you might design a T3 study to interrogate it. And what kind of priorities are attached to that? When you think about designing research to examine this, what are your priorities?
Could I jump in maybe?
Yes, this is.
Okay, I don't want to make, I'm gonna have to answer
I would rather
everything.
not leave. I'd rather have a discussion.
So my first thought, obviously, this is not, one and done thing. There are many probably strategies, but the first thing that comes to mind for me is universal screening of all primary care patients to identify mental health needs.
So your priority is inclusion?
It was screening. I'm not sure if I'm kind of going down the right track, but that's what I was thinking of.
Screening's the outcome that you'd like to, let's think what is screening? Is screening your research design? Is screening your outcome that you'd like to see? Universal
Screening would be one intervention potentially. I think the screening results would be the outcome, but the act of the screening would be one of the interventions.
Okay, so we're actually working earlier in this. Hold that thought, keep that thought. You could put that posted over on the left.
Okay.
For instance, your priority might be that the research be conducted in a representative population, or that the research result in something broadly applicable. Your priority is universal access.
I mean, I guess the priority is to, I'm not sure how to phrase it. I feel like the importance of universal screening is to identify those with unmet mental health needs.
Okay, so to identify, to make sure this reaches those with unmet health needs.
Yeah.
Okay. So Honorata, just
That
incorporate
sounds like
that into it, or
T3.
you can post it on top of it.
Right.
Right. Help us out. Let's keep going.
All right, this is Martha. How about that the outcomes are affordable and accessible to the patient or the population we're targeting?
Okay.
So affordable and accessible services, is that the priority?
Yeah, I'd say.
Okay. That also sounds like T3, right? Because we're still talking about the delivery of care.
Sorry, I have a bell in the background. I can't block. Just give me a minute and keep going with it.
Okay. Any other priorities?
I would suggest that there be some priority on looking at how to be able to change institutions and systems, because those need to be in place, I think, for these other priorities to happen.
Your priority is making this systemic.
Right.
And where would that fall on the spectrum? Maybe pick another
4.
color.
4.
Right.
Right.
When you open, right. Just, so solutions that are systemic change.
Changes.
Okay. And let's go with that one for a minute. What kinds of, so you can put that in T4. What kind of partnerships would you need to address, Angela, to address your priority?
Policymakers, leadership in clinical institutions, and then community-based organizations, and then consumers.
So just put them all on the same thing. You don't need a different tab for
Yeah.
everyone. Just keep editing.
Right.
I'd also include payers in that partnership.
Right. Policymakers, community organizations, payers. There was another one that you said, Angela.
Institutions and leadership of the clinical institutions.
Clinical and institutional leadership.
Yeah, I guess you could put academia in there too, universities.
University.
So you need all of them for policy. Agree. Okay, that was great. Does that warm people up?
Sorry, real quick, would you also add consumers to that last note to make sure it's reflecting, to ensure it's reflecting their concerns?
Excellent. So can we go back and condense? Well, I guess we can clean it up later. So for T3,
Right.
your priority is access and affordable. And we're not sure, and you want universal screening, those are your priorities. And what kind of partnerships would you need in T3 where you're designing clinical trials and outcomes research to address those questions?
Certainly clinicians will be doing the screening and then providing the access.
Let's go green or something. Let's just make them, you don't have, yeah, just clinicians.
Healthcare system in general, healthcare systems.
I'm sorry, what was that one?
Healthcare systems in
Healthcare
general.
Yeah.
In addition to clinicians, I think sometimes the screening falls on the, I'm not sure the right term, Lee, you might be able to help me with this, but like office staff, like people who do the intake, would just office staff be okay? Is that clear?
clinical.
Like in the like clinic
Medical
Oh, clinic
assistants.
staff, yeah.
Mhm.
Thank you.
So now that I'm caught up typing, would it be appropriate to talk about a discrete example? Because over the past couple of years, tried to do exactly this, deploy a mental health screening for PTSD in children through community organizations that were after-school programs locally here in the Delaware, Wilmington area, and it did not work. And I think partly because of so many of these points that were highlighted here. And so I'm thinking through what's the goal of this session that we're talking about. Is it like, coming forward with how this a program might be deployed, or like what are the barriers, or what does it take to construct a pipeline for programs like this?
So what the goal of this session, you're asking, the goal of this
Yes.
exercise? The goal of this exercise is to get this out on the table, because you may know from your experience that there were partners, which you could even add to T3 there, school-based programs, Honorata, that there were partners not at the table that in retrospect, if they'd been at the table, it might have gone more smoothly. But when people are at the beginning of this, they don't know that. And even for your project, you mapped it somehow, but you missed that. And so this exercise is to surface the variety of priorities, the diversity of partnerships, and then we'll try to see how we can get measures and aims and something for everyone deliverables in the second half. I have not been keeping track of the time. I think let's see, we started at.
Someone tell us when it's time to.
Yeah, I'm sure we're getting close. So
Yeah, we start at 1:30.
we really?
Mm-hmm.
Is that possible?
So it's a little after 1:30, yeah.
Okay, so let's keep going. So David, you've thought about this. Can you place something earlier on the translational spectrum?
Early in the translational spectrum, I think the modality of delivery, right? And then so when we talk about mental health, it sounds like there's a mixture of things that have been identified here, screening, but also access to services. And I think some of this goes to, again, more specificity to this, right? So when we say screening for which, there's so many different forms and types of mental health needs that are out there. When we say services, what types? There's so many different types of interventions that are out there. And so I think the primary, so earlier in this kind of flow, T0 through T2, it's, what are the contributors to essentially the mental health as a disorder and its identification in community settings that's not well known. And so, yeah, again, it's so broad.
Could we place it on T2, right? You're so well versed in this. You're seeing the trees, and we need to step back a little bit to see the clumps of trees, the forest. So I think you said something about the predisposing environmental, economic, possibly I'll insert biologic variables that might contribute to mental health. Now, that might not be right on your radar immediately when you're thinking, well, access to services, but maybe it is. Maybe it informs it. Maybe part of the barriers to access have to do with the drivers of the biologic even drivers of different mental health issues. So Anurada, we need you to write.
Mhm.
So for David, you said something about delivery of services. Is that what you said? So would that be finding the right model for delivery of services? Is that how we turn that into a priority for a research question?
Yeah, I think that would be probably T3, T4.
It might be T2 if you're actually testing a model. You're not up to comparative effectiveness yet. You might be testing a new model.
Gotcha.
How about individualized medicine and people's responses to different therapies, pharmacotherapies?
Right. So pharmacogenetics, where would you put that?
That's probably, tell me if I'm wrong, T0, T1 or T1, T2?
It's at least T1. Yep.
Right.
Right. So pharmacogenetics and the more general, before we even get to response to therapy, predisposition, biological predisposition to.
So will they be in different places?
No, they can both be. They're both they'll be different studies, but potentially, but they're T1.
T1.
What about stakeholder interviews? A lot of my work is user-centered, so trying to identify the needs in kind of a qualitative way.
Okay, so say some more about how you want to use that.
I think it would be pretty early on in the spectrum. As I said, I'm new to this T system, but pretty early on, so you can kind of helps drive, it focuses the direction of the research and who you're going to partner with, which clinicians, which, that kind of thing.
So do you mean, I mean, we are the stakeholders right now in the room. We're having this discussion?
Oh, I'm sorry. Well, I mean, like, related to the health needs. So looking at who is affected by mental health care and identifying those stakeholders within the geographic location you're going to do this research in.
Okay, so is that a priority? Is that a method? I mean, it might be a priority to use that method. Others, help me understand. I don't want to be overly dogmatic. Help me understand how you would place that. Where do you think that fits?
Maybe it's some kind of, it's an overall assessment to get the feedback of folks who are important and have a stake in an issue. So I guess I don't remember if you actually said you can do it in interviews, but you can also do it in survey form and things like that. Just to know what these key representatives think and needs to be done.
So to me, that's a method. And it's expressing the priority of including the stakeholder perspectives in the design of the research, which I think we could apply across the spectrum.
Might be a method, but I think it should move as a priority because I think getting the voice is really important. So that's my perspective.
Right. So can we reframe it not as can we reframe it? To me, I'm a little bit stuck on the interview as a method, and the principle is including stakeholder perspectives.
Inclusion as a priority?
Sure. I like that.
Inclusion.
Great.
And
So-
that's going to be across the spectrum, right? It's
Right. So why don't you put
spread.
parentheses, all phases,
Mhm.
and then we don't have to worry about where it sits.
Right.
Okay, so let's talk about it must be time to go back soon. So let's just pencil in some partnerships here for T1. David? What kind of partners do you need for your T1? Or anyone?
Well, T1, you want patients. I mean, people who are directly affected by behavioral health or mental health issues.
Okay, and who else?
Pharmacologists.
We're on T1, Anuradha, not T0. Pharmacologist. What else? Who's going to do the basics? So the pharmacologist may be using the result. Who's going to design the research and conduct the research? Karen, you want to speak? Right?
Academic researchers at the universities, at academic institutions.
Well, certainly geneticist.
Mhm.
Right? That could be a vendor. That could be, if you don't have an academic partner, you could outsource it, for instance, but you'd certainly need that expertise in interpreting and placing the research in context.
I would also emphasize the advocacy groups because at this level, very often, the research is really triggered by advocacy groups of patients. So it's not only patients, it's really advocacy groups also.
And they often know something about the phenotype
Right.
that is not captured in the literature. And they'll have a lot to say about how their fears and aspirations for what to do with those results, how to keep it out of the hands of insurers, et cetera.
Right.
Good. So we've got that for T1, T2 partners. Let's pencil something in and let's go back. We'll need to go back to the group. I'm sure we're overdue for that, but no one has tweaked us. I was just looking to see that we know how to go back. We do. Okay, for T2, partners for T2.
Well, it's kind of the same people, advocacy groups and patients.
Well, you're also designing a clinical trial, so you need also
a clinical trialist.
You can write the same people down on Anuradha because it's valuable. Advocacy groups, patients, clinical trialist, what about, so mental health issues are particularly sensitive. What about, are there any other groups that might be involved? Oh, hi, Dana.
Hi,
Yeah.
I just wanted to see how much time you guys wanted till we came back together since we're running a little bit behind.
We were wondering when our time was up.
Yeah, we forgot to sign a timekeeper, so we're
Uh,
ready to come back.
Same. Okay. So,
Come back. We can come back in about, give us maybe a minute to
yes,
finish up.
sounds perfect.
Great, and we'll rejoin.
Okay.
Try to put a timer on that I can see.
Institutional review boards.
Yes,
IRB.
absolutely.
And healthcare providers?
Mhm.
Anyone else? Maybe pharma? Depending on, I mean, we're doing access. But we might.
Insurers, particularly for locally based coverage such as Medicaid and things like that.
Great, okay. Save, yeah.
Mhm.
And then is there anything that's missing that you, Honorata, maybe try to just consolidate
Yeah.
T3, the one posted? And then we should, so when you click on the breakout, you'll be able to go back to the general group,
Right, the translational spectrum,
right?
right.
And so Honorata, you keep this link because we
Mhm.
might be called on to share it. And
Sure.
who's David, you're our discussant if we're talking about it, right? Okay, let's go.
I'll have this up so I can pull it up whenever.
Great. So you go to the bottom, choose breakout, and we go back to the general group. See you there. CE across the translational spectrum. Okay, we came back. Hello, Emily, you're from the other group.
Mhm.
Did David make it? Mhm.
Well, he was in the wrong group. He'll figure it out.
Somebody was in the group that just disappeared and hopefully made their way here.
Okay, there's David. Hopefully the rest of them are coming soon.
It says there are 0 people in our
Right.
break. So
Yeah. Yeah, they're still in their subgroup, so I'm just going to join
Yeah,
there
we're-
and see how long it's going to take them.
We're supposed to be coming. I think everybody's trying to figure it out.
Oh, good. Oh,
I was
thanks,
just-
Dave.
David, I was just thinking, were you in our group and off my
No.
page and I ignored you entirely?
No. I just joined, so. It was a little, you have to rejoin this group, but I don't know if that was clear.
Well, that was a bait and switch. They came to ask us to come back and then keep talking until they come back. If you have something else you want to, you meant to have Honorata add to our board. Okay.
Karen, maybe you need to go in there.
Yeah, because now they've just added one additional person.
Hello. We did the same thing.
Okay, so everybody should be back in the original translational spectrum group. So I'll meet you back there today.
Right. No, wait, how do we get back there now? I'm-
Just click on the breakout room again and choose the main translational spectrum, not a subgroup. The
Got it.
main
Yep, that's where I
translational
was before. Okay, got it.
Yep, okay.
Interesting.
We still only have 13 participants. Oh, here we go.
I wonder if they went back to the general group.
That's where we are.
That's
No,
what we
this
were,
is the general group of this breakout. I mean, the general workshop.
Oh, so they're not here.
no,
So they must be in another one. Are they in C? Did they go to the wrong place?
no one's in C. That one's closed out, and so is A, which was our.
He thought maybe they went back to the main at the top. I don't even know how you get to the top.
Yeah, it says that there are 12 in here, but when we come in, there's
There's nobody.
Right. They're lost in hyperspace somewhere, but it does say that there are 12 in that breakout.
Mm-hmm.
Oh, there's
Oh,
Dan. Hey,
where are you guys?
well, we're back in the original, which is the
The subgroup B is what we're in.
Oh, I don't see that anymore because we're in subgroup B. Okay, so we're back in translational spectrum, but there's only 11 of us there.
yes, same here. We're in there, but they're only, well,
So
Uh-oh.
everybody in the subgroup B, we need to go into the CE across translational spectrum, join that one, and then there will
Yeah.
be 23 of us in there.
Okay, all right.
Okay?
Yeah.
Here we're going back there. People are moving in there.
Have much broader ideas as well as to what to engage with. And then rather than having that engagement occur all the way at the end when we're talking about dissemination of results, bringing that further up. And I think we talk about that often, but how that actually happens when we're thinking about very specific things and specific interventions, specific projects, specific outcomes, how to maintain that larger view, I think is challenging, yet also what I think people really want to do.
Right. So I think it's like this. It's
Hi, Karen. You're muted.
I wanted to make sure you guys are all comfortable being in your group. I think what we're doing is we need to go back to the translational spectrum group. So right now you're in the main general meeting
Okay.
before we broke into our groups. So everybody in this section needs to go to the translational spectrum group.
So we went to the wrong place.
Yeah, it's okay. And we couldn't find you. It was like a ghost, but now I found you. So let's all go back to the translation. So just choose under the breakout rooms, the translational spectrum, CE across the translational spectrum. And join. Yeah.
welcome.
We're pulling everybody separately. They're coming. It's just taking a little longer.
So Karen, was it the case maybe that they click leave the room instead of?
Yes, they
choose
clicked out
another
of
breakout?
yes, instead of joining a different room, they went back to the original meeting, but that's
I see.
okay.
I
We're
see.
having quite a interesting conversation.
So where's
So we have 21 now. So I'm just going to go back and make sure
where's
that there's
Jonathan though?
right. He should be coming.
Funny.
He's the only one in that group. There's only one in group B.
There he is. Hi, Jonathan. Welcome back. All right. So do we have everyone?
Yes, there's only one person left there.
All right. Jonathan, did you want to lead the check-in?
So I would say our group did a great job at the distal end of translation. We were light on the early translation, but who from our group would like to present? I don't remember, Vicky or Erin, was one of the two of you going to present the summary of our Jamboard?
I can, and then other group members, if you'd like to jump in, feel free. Oh, this was looking a lot more organized when I was just in there, but I realized I overlapped a few. So as Jonathan noted, we did, can you hear me?
Yes.
Okay, yeah, I'm yellow. We did start on the T4 end. As I realized, as I stated the situation, we talked a lot about elevated blood levels in kids.
Hey, you guys, everything okay? Good. Dana, you can join the regular meeting, the Spectrum meeting if you want, or you can here. It doesn't matter.
All righty.
Regardless, what will happen is what you've recorded now will show up as one recording. And when you go to record, if we go back into these smaller groups, you can just hit record again.
Okay.
Okay. Thank you so much.
Thank you.
Uh-huh.
Good luck. You did a great job, guys.
Yeah. Oh, well, we still got until 1:30. I mean, until 3 o'clock. So we've got.
All right. See you.
Yep. Thanks, Kevin. Were you able to get everybody into their groups?
Either that or they left.
Yeah.
I never heard from a few of them.
Okay.
I
That's fine.
tried to engage with them a few different times, but
It's okay. It's all right. So thanks so much.
no problem.
We'll see you back here, I guess, close to 3 o'clock.
Is everybody going to come out of their rooms?
Probably not, but
Okay.
I'll probably pop back.
Sure. Okay.
Okay.
Yes. And that was kind of like a challenge point for us in figuring out, like getting to that T0, what kind of foundation. And I think that's some research that I want to do on my end.
So we did talk about the chemists who helped develop the assays, the investigators who developed the mouse models. Rhonda, I was remembering our colleague who talked about nose pokes and as a measure of cognitive ability of mice and the reduction in nose pokes as a response to lead poisoning was part of her assay development. So I think we have some work to do in terms of understanding who the basic scientists are. But let's, Erin, just talk about the shared priorities here.
Sure, yes. So the first one being that elimination of disparities. That was the top priority, right? So thinking about who this is affecting across the nation, what children may be at higher risk based on their environmental factors. And in the same vein, how are we communicating these regulations, which ties greatly in with health literacy? Because if any, we know that any scientific rule is communicated out and translated out, it has to be understandable at the patient level. And we're talking about very young population, so that trickles to the parent and the school setting. So considering those priorities is key. Was there one more, Jonathan?
I think that's good. Let's go, Rhonda, to your group now. Thank you, Erin.
So David Chen is going to synthesize for our group. And David, I don't know if you have the link or if Anuradha.
Do you want me to share my screen? I have it up. Whatever.
That might be easiest. I do have it as well, but if you share that will be quicker, I think.
So David, I'll let you walk us through this.
Yeah. So
and I think your general remarks about the experience that you made before were also interesting if you want to share those at the end.
Yes. So what we focused on was access to mental health care. And this is a very broad area. And I think naturally the conversation gravitated towards the T2 to T4 areas. And so we were talking about service models for delivery of care, screening, access in different environments. A really important point was equity and access and inclusion and the voices of different stakeholders, including patients as well. And then as we were filling in these different priorities and partnerships, realizing that thinking through areas from T0 to T2 was important, but more vague and more ambiguous for us to come up with initially. So kind of taking that step back and looking at the process of how we came up with these priorities and partnerships here, we kind of recognize that it's, I know for myself at least, very easy to focus on specific trees or little clusters of trees, but being able to take a step back and look at the forest to say, you know, there are a lot of overlapping groups of persons. For example, advocacy groups came up in a number of these partnership columns. Pharmacologists, geneticists were groups that we didn't think of initially, but were really important in kind of probing that upstream area, so to speak, from like T1 or T2. And then so I think a lot of what we were doing was trying to understand these different classifications, and then what does it look like to begin to synthesize those things together and then having things move across those categories with the different partnerships. Is that a fair representation of what we talked about?
Anyone else from the team want to chime in? Well, I think the group did a great job at what was initially sort of, there was, you know, silence facing the matrix. And then people warmed up and sort of began to see that you can do this. And I think obviously the difficulty populating the left end of the spectrum is we don't have those partners in the room, which is why you need those partners in the room to help you have that discussion together.
So think of the adage we heard this morning, no research about me without me. And it's clear that to make this work in building full spectrum translational research teams, it's incumbent on all of us to bring the partners to those meetings, to bring the basic scientists into the discussion, and also to bring the policymakers, the regulatory, those who have regulatory responsibilities, because we depended heavily on both of them in our discussions, but we were speaking on their behalf. So I think that same principle applies there.
Yeah, I think that this might be my cue to chime in a little bit here. As a community member, you know, within this conversation, quite honestly, I found the process very confusing. And I think that I would have benefited from a little more explanation about the spectrum and what you'd be looking for in the process before actually jumping into the process and trying to operate the process. So all that to say that, you know, having the various stakeholders, community members, you know, in the room with you means that you need to help them not only give input in, you know, in terms of the questions, but help them understand the process first and then go into that so they can more fully participate. Because I didn't really feel like I could participate that well.
Sorry, you felt that way. Go ahead. We're going to have another round at it. Realize, of course, this process usually doesn't take place in 45 minutes.
Yeah.
It takes place over a series of meetings, over a series of, you know, days and weeks and months, that we don't try to get all of this articulated in 45 minutes because it requires reflection. And I agree with you, a sort of understanding of what can happen in each phase. And we do that by sharing examples and, you know, and suggesting possibilities. Jonathan, do you want to comment a bit more on the
I
process?
think of this as speed dating. And so part of it is really building the relationships. And this was just an attempt to encapsulate what that process might look like. I think one of the disadvantages, one is it's the short amount of time, and two, we had very limited representation in our two divided groups. And I think if we had a more broad representation, Lee, this is, I think, a reminder that an activity like this would benefit from maybe some specific invitations, bringing in a basic scientist to each of the rooms, bringing in a policy or regulatory decision maker, et cetera, so that we're not speculating, because this really left it up to us to think what would be important to them. And so, Gwen, I hear what you're saying, and again, this is just a limitation of how tabletop exercises can work, but it's really meant to show that this is a process that unfolds and can unfold over a much longer period of time. But the key issue is having the right people around the table, and also recognizing not everybody can be there at the first meeting. So having a process in place that catches people up so that every time you have a meeting, there's a way of bringing new people in. We had some turnover among the clinicians, some turnover among the laboratory investigators in our experience. Interestingly, the patient participants who were part of the research team had 100% retention across that process, which I think was very gratifying to them, to us, but recognizing that turnover is intrinsic to all the work that we do. So we need a way to bring people in and bring people up to speed so that they feel comfortable contributing and participating.
Thank you.
So at the risk of making people feel even less ready to take on the next part of the exercise, in the next part of the exercise, we were going to try to focus on aims and hypotheses, measures and outcomes. So recognizing that we don't have basic science representation in the two rooms, I think we should just stick to the T3, T4 cells of this, and then use this again to go back and say, well, who are the basic scientists that we might need to reach out to? And similarly, who are the partners on the implementation and sustainability side? Who are the community organizations, the advocacy groups that really need to be part of this process? So this, again, is that iterative process that we need to put into place so that as we identify those needs, we are able to continue to bring new partners into this. So are we ready to go back and do the second half of the exercise?
So how should we manage our time?
That's what I was gonna ask.
Technically, we have 20 minutes. So if we're going to have time for discussion, how should we do this?
Well, another option is to not separate and maybe to work through these two exercises jointly.
That's what I was gonna suggest,
I think
yeah.
that would be fun. Jonathan, why don't you lead?
Okay, so let's start with the mental health question, since I need to, as a new partner to this, need to quickly come up to speed. So I have some sense of it, but what would be the initial hypothesis that brought your team together?
Can you share the screen, Anurata?
So David,
we didn't articulate a hypothesis. We articulated priorities.
so what would be the hypothesis that underlies or derives from that priority? How to improve access to mental health care. So to me, there's an underlying assumption that access is limited. So how would you articulate that in terms of an aim or a hypothesis?
One possible hypothesis is that access may be limited due to stigma regarding mental health, which brings specific barriers to access to care and appropriateness of care. So, we have to bring in the whole stigma issue, which I believe can fit at least T1 to T4.
Okay, so let's stay with stigma for a moment. So let's locate that on the spectrum. I'm not sure where it fits into T1. I could see it closer to T2 or T3, perhaps.
Well, I'll give you an example for T1. While we as clinicians and researchers may see the the goals of individual medicine as really providing the proper therapy to each individual, there could be the potential of concerns of differential treatments for different groups, for example, race, ethnicity, et cetera. So that I think there's just a potential for misinterpretation of what individualized medicine is and how that might contribute to, I see it as decreasing disparities, but taken from the perspective of a marginalized group who's always had difficulties with medical research, they might see that as increasing disparities because we're giving different therapies to different types of people.
So you're looking at the heterogeneity of treatment effects as a way of trying to personalize treatment and to understand the underlying mechanisms. So let's stay with the mechanisms, try to come up with an aim that might get at those different mechanisms that might mean that an intervention could work differently across different populations. How would you turn that into a testable hypothesis?
We need help with that one.
So let's just assume, not being a geneticist, someone's cringing somewhere. Let's assume that there's an allele or a gene or a area of interest where the hypothesis is that there's some set of variants that might be associated with a better response to a particular treatment as opposed to a poorer response to that treatment. So what would be interrogated there would be some genetic profiling to see if that holds up. If you look at groups that have differential treatment responses, that's supported by some genotype that reflects that therapeutic phenotype.
So could the aims then be identify the different genotypes that lead to different treatments? Or that
at a very high level it is. That's probably too exploratory to actually operationalize into a specific experiment, but yes, that's the general idea.
So Lee, let me try a different example that came out of our research where we randomized women to a group behavioral intervention, HIV positive women to a group cognitive behavioral intervention. And we conducted it based on the feedback of our community participants that we really needed to target 3 different communities: the English speaking, the Spanish speaking, and the Haitian Creole speaking population. So we recruited interventionists who were bilingual in any 2 of those. We found some very significant heterogeneity. The English speaking women benefited from the group behavioral intervention. The Spanish speaking women benefited. The Haitian Creole speaking women were actually harmed by the group behavioral intervention. And when we went back and tried to understand it, it was exactly the concept of stigma and the stigmatization of being HIV positive that made the Haitian Creole speaking women very uncomfortable to be in a group that was a group of HIV positive individuals. So there's both a cultural component, linguistic and cultural component here to that heterogeneity, but also a stigma and anthropologic component. So how would we try to investigate that more deeply? What would be our measures of success in an intervention like this?
Increasing the communication of the people, the women that were speaking Creole, increasing their participation.
Okay. So again, this gets back to representation and participation.
This is a deliverable, right? or an aim.
Measure.
Yeah, so this would be
Well, actually, I'm
in the
not sure
full.
where you intended it to be.
I'm not sure I understand what's the intervention here. Did we define the intervention?
Lee, we'll go back to you on that. What was the intervention you were thinking about that would directly address stigma?
Well, I may not have thought of it as a specific intervention, but a specific hypothesis. And the hypothesis being that any intervention for a mental behavioral health issue, we need to assess differential uptake due to multiple different identities people have or multiple different demographics. Does that make sense?
Yeah, so are you kind of like, you are thinking like of implicit bias of providers and how that impacts how treatments are given?
Well, yeah, I think we could create hypotheses on both the provider side as well as the recipient side.
Right,
But-
so
but yes.
I thought I heard you saying that perhaps the expectation of implicit bias or the fear of implicit bias made some populations less receptive to treatment.
Yes.
So there are a lot of, there are a lot of hypotheses to test there. The reason we're struggling with this is there's a lot packed into this. The cultural piece, the perception, the intention, the therapeutic outcome.
Right.
So
Did we decide where on the spectrum we thought this would fit?
Yeah, I would think this is a cross-cutting issue that you probably could apply to all different levels and or to research, questions at all different levels.
So it depends on how you interrogate the question, right? Whether you're doing it with I can't think of a T1 approach, but whether you're interrogating it behaviorally or some other way, whether you're doing an intervention or being observational. I'm not familiar enough with this, with interrogating this kind of question to tell you how to suggest how to design a proof of concept, what you would call T1, because I'm a very biological T1er. So.
Well, I can think of, just thinking of assumptions. I think we have this kind of cultural assumption that like science is objective and free from our own biases, right? So in the development, you see that kind of like even with mouse models where they were only using male mouse or mice, right? And they weren't including female mice to see kind of what in that kind of animal model T0. So just assumptions, I guess we also have about race. And that's obviously not being applied to mice, but that is apparent in every single stage of the translational spectrum, right? So that introspection by scientists at each level of like how their assumptions about race, gender, language, ability, like any of those things affects. That doesn't really help either, but I'm just trying to think of like T0 stuff, and that's an example I can think of.
I'm not sure if this fits into this, but also as a clinician, what I find is that we have a lot of resistance because of cost. Since a patient has to pay a copay every time they see a clinician for mental health, they're reticent, and so even if they had the greatest insurance in the world, they still have to do the copay. So I'm not sure where that fits in any of this, but.
Well, I think that's one of the barriers. And so it sounded like the original question about differential access to care depended on first identifying what the barriers are and whether the barriers are experienced differentially by different members of the population. then there are potential interactions of stigma plus those barriers, stigma itself being a barrier, but this becoming a way that additional barriers become magnified, and the cost barrier may be different based on the income or assets that you have, or the insurance status that you have, or the access to mental health specialists in your community. So all of those become measures that can be assessed. I think the definition of the measure of success here is to improve access to mental health care and to improve or to reduce adverse mental health outcomes, depression, anxiety, substance use, etc., in the populations that are being served. So that's a much more distal outcome, but I would argue it's probably the most important one we should be thinking about, because that's in the end going to determine whether all of this was worthwhile. So this is hard stuff. This is not easy. And I think the gaps and the pauses here are just a reminder that, again, we need a broader representation of collaborators in these discussions, because they would help us more, I think, explicitly articulate that. But Dana, let me go back to one of the points that you were making, that there are all of these implicit assumptions baked into the studies that don't necessarily are not apparently obvious to the participants, but will directly affect the conclusions and the generalizability. So what are some of the strategies that become really important to guarding against those implicit biases and improving collaboration and participation?
Yeah, I mean, as an anthropologist, I think you're always trained to question your own biases, right? And we always write about positionality, right? So my position as a well-educated white woman, like how does that affect how people perceive me, who will talk to me, who will not talk to me? That is something we always consider when doing our research, right? And I don't think that kind of thinking through your identity is always something that's taught in other disciplines, especially when you kind of go up the translational spectrum, because they're like, well, I'm not talking to people, so why would that matter? And so I think for me, it's really about reflexivity. It's really about questioning all the time, like, what are my assumptions about a group of people? Because we all hold assumptions about people. It's, you know, we're raised in a patriarchal white supremacist society, so we all have a lot of isms that we need to work against constantly. Even as someone that's, you know, I study these all the time, it's still things that will come into my thought processes where I'm like, whoa, okay, let's like question that, right? So really reflexivity and thinking about how your identities, whatever those are, both the ones that people can see and the ones that people can't, how that affects the research that you do, and how that affects your interpretation of the research. And I think polyvocality is really important in that, right? So we're talking about including a lot of different voices within this process. So making sure you're not the only one speaking on behalf of a group of people, or that you're, what you're hearing, you reflect back to community members to say, is this right or not, right? And that's something that I do in my current work with Indigenous populations in both North America and in Minnesota and Ontario, is, you know, we're constantly giving back our results and saying, you know, this is how we're interpreting this. Does this ring true for you? You know, and it's about data sovereignty, and they get to make decisions on what sees the light of day and what doesn't. So that's kind of, I think that's really important, is just reflexivity on your own stance, especially in the scientific process, which again, I think our culture assumes is kind of free from bias and judgment, and it's objective and all these other things, but we're all trained into a cultural way of thinking about things.
So does the team give you feedback, Dana, the other way? I mean, do they sometimes, I don't know when you use the phrase call you out, but something like that? Do they inform you and just kind of call it out if they feel like you're biased or not looking at it the same way?
Yeah, absolutely. I mean, and that's part of the process. I don't take anything, if somebody said earlier, everyone has to be at the table as a learner, right? And I really take that to heart, that I certainly don't know everything about, the Native American experience of people who are caring for loved ones with dementia. So I need to come with all I can do is interpret the interviews that I'm qualitatively analyzing and bring it back to them. And, I haven't really had any call outs, I guess, quite yet, but it's been more providing context or ways for me to understand it better within kind of like, oh, well, this is what they mean when they say this, things like that. So I'm sure it'll happen, and I'm excited for that day because that's a learning opportunity for sure.
Yeah. Well, so much of this is very eye-opening to me, and I really appreciate, yes, you're hearing pauses from all of us, but that doesn't mean that I'm not engaged or intrigued. I'm just thinking, I'm processing a lot of this because it's foreign to me. It's foreign to think through the whole process. It's foreign to, it's enlightening to hear what Dana just said about even though you're trained, constantly questioning yourself, because I probably don't do that. I mean, I probably rarely do it. I think I kind of read back with my team and the people I interact with and my collaborators and that, but really doing true community engaged research, it's going to be a different, that is where my inherent biases or whatever my cultural norms are going to be, questioned or exposed. And I'm saying that in a nice way. I don't mean exposed like I'm going to feel horrible. I'm just going to use it as a learning opportunity, but interesting.
Yeah, Erin, do you have a question? I think we're running up at the end of time. So no, go ahead.
It was just a quick comment. I was just going to say, I think collaboration such as this helps us to see where we can create spaces in our current research to up the ante in that community engagement and find those niche areas that could benefit very highly from increased engagement. And we really owe it to our populations that we're working with. So thank you for the opportunity.
And education is one of those currencies. So I was asked that question earlier this morning about waiting for the results of studies. And we have to wait a long period of time for that, but we don't have to wait to learn from each other. And as I mentioned, when we brought the team together to study skin and soft tissue infections in that first iteration, we would have a clinician present a case history of a patient that they saw. And at the same time, we'd have one of the laboratory investigators presenting the results of a publication so that we were learning together, learning from each other. And that was a forum to ask questions that might be outside each of our individual area of expertise, but created, I think, an ongoing dialogue that was extremely valuable, that in the end helped us focus on recurrence as the unifying priority that was shared by every member of the team, and that was amenable to the second study and hopefully the next study that we do. So I think this has just been a rich experience hearing from both groups and recognizing that this is not easy. It's a struggle. It doesn't happen in 90 minutes. It takes time, but it begins with that first step, which is that conversation. Here's what I'm interested in. What are you interested in? Where are the areas of commonality? Where are the areas of divergence? And how do we build a functioning process and a team that we could work together, learn from each other, and continue to open up ourselves to new partnerships?
David, do you have a comment?
Yeah, quick question. So in trying to formulate this, it feels like a lot of this is very investigator driven, particularly on the research investigator, usually someone that's backed by an institution, a group, some kind of resourcing. And yet it's also polling kind of across the spectrum, what are the needs that are identified? How have different experts here, different groups approached the situations where a compelling need or gap is identified, but there isn't that kind of cohesion around the resources, the interests, things along the spectrum to be able to address it, yet it's still important, and being able to kind of reserve or carve out that space to recognize that importance, to be able to return to it when there are resources, or to be able to direct resources in that way. I don't know if that makes sense as a question.
I think it's a great question, and I think it really comes down to strategy, that not every grant can answer every question. Some of this is building a portfolio of grants, and some of it means taking turns. So if there happens to be an RFA that's specific to the comparative effectiveness or population health question, the reciprocity would suggest, okay, let's focus on that. We'll try to build those resources in a way that keeps the team together, keeps the program funded, but it may focus on the T3 or T4. And similarly, my hope would be that the basic science investigators would come and bring an RFA that's relevant to their work, but recognizing that it isn't just about collecting the specimens, it involves building that team over time. Rhonda, did you want to add to that?
Yeah, there's something I want to bring up. I don't feel completely qualified to discuss this topic, but the pandemic and the development of the mRNA vaccines is this sort of incredibly hopeful but messy example of both engagement and lack of engagement. So the mRNA technology had probably been in development for a decade or more, and had been, tried in some cancer environments. And then suddenly we had this incredible rapid translation from this probably T1 living technology to T3, T4 sort of instantly.
Yeah.
And in some of the ways that communities were left behind was because there was a lack of anticipation of this possibility, and a lack of engagement of all the different entities that would be needed to understand not just delivery, but dissemination, implementation, vaccine, quote, hesitancy, poor communication from the scientific community, confusing communication from the people in the scientific community. So it's kind of this perfect storm of both effective and ineffective full spectrum translation.
I am so glad you brought that up, because that's been top of mind for me almost during this entire pandemic. And I have struggled with my friends and colleagues to, they're hungry for information, and we just didn't do, like you said, we moved too quickly, we weren't ready. And I gave them information, but and then all the information on COVID that was a benefit that was freely accessible. You could get any paper on any publication on COVID, which is remarkable. I thought it was fantastic. But then the downstream effects of that is who's going to give the summary of that, or who's going to explain it from a lay person perspective to the public or to the community that really wants to know, that is dying to have their questions answered, and nobody's answering them.
And media was not the best translator of that science.
Say that again.
I said the media was not
horrible,
the best sort of honest broker of that information.
No. And that's what happened to us. Media, social media, and it quickly got taken out of our hands, I guess. And but I think we can learn from that. And I'm so glad you brought that up as an ending, because I really feel that there's many, many lessons to be learned from COVID. And positive ones. And even today, this breakout session was really helpful to me because I think it helped me understand where some of those gaps occurred. I mean, I could get some of them, but not, I just didn't understand how something so exciting and so, empowering for many could just fall apart, that had so many other things that were not right about it.
And let's think about what a full spectrum team might have looked like if the basic scientists were working in settings that said, the cold chain requirements are not only going to be difficult in the United States, but they're going to be impossible in large parts of the world. So we need to work on either a way to deliver that or an alternative to cold chain, number one. And number two, while we were all waiting for those vaccines, for that pipeline of effectiveness studies to come out, we didn't start the process on the community engagement side of education and the importance of vaccine uptake, because by the time the vaccines came out, there was already so much counter propaganda about the harms of those vaccines that wasn't based on the evidence, it was based on conspiracy. And so I think this was a failure of full spectrum translational research to be intentional about what do we need to do to empower the basic scientists to accelerate that pipeline for discovery was nothing short of a miracle. But that pipeline for delivery has really been a failure, particularly in certain communities.
I want to be respectful of everybody's time because we're going over. So I just want to make sure that whoever needs to leave, feel free to. I would like to kind of start ending things up. Dave, you have your hand up.
Yeah, it's not a big deal. No worries.
No, go for it.
Yeah, go for it.
I guess related to the discussion is, oftentimes our T0, T1 investigators come to the table with their question ready that they want to answer. So how do you get them to engage, right? And it probably would have helped with this pandemic question as well. How do you get them to engage, other community members, I guess? Is there any experience there?
Well, it's really bit by bit. As I said this morning, it's sort of, one thing is to be led by peers. So something we did a few years ago is we took some of our successful laboratory scientists who had translated and we interviewed them. And we excerpted that into 2 or 3 minutes about how community engagement informed their science. Because we had a researcher who works on DNA replication error repair. But she works with the Fanconi anemia population, which is a genetic disease that is, its foundation is errors in DNA. So there are many, many mutations, many early cancers. And she was very eloquent about how the population was integral to advancing her research. And that once a particular problem was solved, like aplastic anemia with bone marrow transplant, nobody knew what was going to happen next because no one had lived beyond, the age of late teenage years. And so then it was only from the population that they could learn what the important questions were. And the important questions had underlying biology. So it's a long answer, but just by having someone like her talk about how the community priorities and needs can actually change the research question is powerful because they do listen to their peers. And we have other examples of investigators who are able to they can't always articulate it, but some who articulate very well how it opened their eyes and changed their science. What happened to Jonathan? Oh, he was on the phone. So
well, I think what we're talking about here, Dana, you're an anthropologist, about culture, but this is truly a culture change within research, within the culture of research. And I think we have a great start. It's going to take a while. It's going to, sort of diffuse down to the earlier translational levels slower and slower. But I think a conference like this really helps jumpstart that. So I want to thank everybody for participating. I want to thank our speakers and facilitators. My hope is that, as we log off, this isn't the end. If people have questions, we have everybody's email address. Feel free to email the conference organizers, and we'll make sure that the communications get out. But thank you, everybody.
Thank you, Lee. I learned so much.
so much.
Thanks, everybody.
Thank you, everyone.
Pleasure. Thank you,
Thank
everyone.
you.
Have a good day.
Thanks, Dana.